We're delighted today to have Helen Mayberg from Emory University joining us. Helen did her training at a variety of places that you'll recognize at USC, residency and fellowship at Columbia Medical and Johns Hopkins, faculty appointments at UT Health Science in San Antonio and University of Toronto, for coming here to Emory, where she's jointly appointed in neurology, psychiatry, and radiology, and holds the Dorothy Fuqua Chair in Psychiatric Neuroimaging and Therapeutics. She is, as I'm sure many of you know, one of the recognized leaders in neuromodulation approaches for treatment-resistant depression. And very excited to hear today about kind of her latest studies and pioneering work in this area. So Helen, thank you for coming.
Thanks, Chris. Well, it's nice to be with you, and what I'm going to do is give you an overview of this project that, I don't know, I've been doing since before many of you were born, it will feel like, which is about deep brain stimulation for depression. And just to get started, it's been supported by a number of grants. I'm going to be talking about what we call in medicine the off-label use of a device. That means what I'm going to tell you about is not approved by the FDA, but we use devices that are approved pretty much by the FDA, and we are repurposing them, but still have to work under very carefully controlled conditions with the FDA. There's a patent involved that we filed back in 2003 that was issued and then licensed to a company. And I consult to that company and do get some fees for that licensing. Didn't help in terms of their clinical trial, but that's another story. I want to introduce you to my team because I want you to appreciate the variety of people that participate in this kind of study. These are people that are currently involved in the studies at Emory. There's a clinical team that requires a surgeon and psychiatrists and people to really interact with the patients. There's a team of people involved in biometrics and mechanisms that pretty much covers the board of imaging, electrophysiology, and psychophysiology. I'm really trying to get metrics of what's happening in your brain, what's happening in your body, what's the behavioral readout on people with depression with things in their brain. And then there's the modeling, which is how I know Chris and Rob Utera. We all have a graduate student, Vineet Tirivati, who's a BME student here, you may know. And that it also involves computer science and some machine learning. So given that this is a broad audience, there's probably something for everybody here. What I want to introduce you to is the idea of diseases of the brain being disorders of circuits. You've heard the new buzzword connectomics. Basically, it's fancy words for what we've always known is that brain areas are wired together. We used to not be very smart. We always knew there were lots of cell types, but we grossly thought about how big swaths of brain areas talk to each other. If we whack somebody in the head or they had a stroke and you lost a big area of brain, well, you made inferences about the role of that region in behavior and also what was the wiring diagram of how those regions talk to each other. And you could look those up in anatomy books going back hundreds of years. And now we have scans to look at it directly. But concept, whether or not you think about Parkinson's disease, which was really in the modern era the first evidence-based application of brain stimulation to a circuit disorder, started in tremor, but really is the workhorse in Parkinson's disease, is how can we build a model of a disorder like depression, which doesn't really seem like the kind of thing that you'd think about a circuitopathy. But I want to convince you that like Parkinson's, where there's problems with slowed movement and gait, there's also slowed thinking and trouble with your emotions. Similarly, it's a similar kind of circuit in depression, where it's predominantly a mood problem, but it also has problems with motor and cognition and autonomic or drive states in the hypothalamus. People don't sleep, they don't eat, they have dysregulated drives and libidos, and they have trouble with stress hormones. So that think about the idea that symptoms might map to a particular region or sets of regions, and that what DBS does is it impacts specific nodes or pathways or networks that might impact one or more behaviors. And I think that thinking about wiring diagrams and that a region, a pathway, may be logically targeted for a particular symptom, that these things all work together, and how to think about networks in that way. So what are we talking about with deep brain stimulation? I've used the term a number of times. I've abbreviated it. It's basically an approach, surgical approach, that involves implanting, at least now, implanting small electrode. You can see the equipment on the left, the electrode. The active contacts, there are conventionally 4 of them. New ones, you can have 8. They're spaced along a wire that's encased in silicone that under MRI guidance, you can pretty much, a surgeon can put these pretty much anywhere in the brain that they want. It's not restricted to the surface. It's not restricted to subcortical areas. It's not restricted to gray matter or white matter. It's pretty much, well, as surgeons say, you know, there's no brain area safe from them. And so it's really just a matter of ensuring that it's a safe trajectory and target, because there are blood vessels, there are things you don't want to hit. But the way you should think about it is in an operating room with a patient awake, you can put a stereotactic frame on their head. You can kind of see the setup here. Patient's draped, they can talk to you from the front, they're awake, they kind of lay on a lounge chair kind of setup, and you can, through a small burr hole, place a guide cannula, and then place, having determined the location, the trajectory, the safety, avoiding vessels and whatever else you might want to avoid, place this lead where you want, and have one of these contacts be, or more than one, be where you want them to be. It then comes out of the top of the head. It's attached to a connector cable that then is under the scalp, and then you can put in another cable under the skin in the neck and hook it up to a little battery pack, the IPG implantable pulse generator. That usually goes under the collarbone, and the whole thing is internalized. And with a little magnet, like you do with, you know, charging your phone, you can sit with a little PDA and adjust the frequency, the current, the pulse width, which one of the contacts, one or more, and basically drive current to the place in the brain that you've implanted. So that's the device. So the issue is where to put it, and who to put it in, and what you want to have happen. So to cut to the chase, because I want to cover a large ground, you might say, well, brain's a big place. I mean, how'd you decide where to go to? Well, that was 20 years of work. So again, so before your parents were born, that basically we looked at different groups of depressed people. We studied them with PET scanning. fMRI wasn't even around yet. We mapped the metabolic and blood flow signals throughout the brain that distinguish depressed and non-depressed patients. We started to treat people. We looked at how the brain changed on various drugs, how it changed on psychotherapy, how it changed on placebo, how it changed with DCT. We compared patients who had neurological depression or regular depression, and we started to build a map of the brain areas that participated. Resting state, not getting fancy. We also wanted to get an idea about what brain areas were most important to negative mood. Because when you see a depressed person, people don't sleep, their appetite is disrupted, they lose interest, things don't feel pleasurable, might feel guilty. There's a number of signs and symptoms. But the one thing, which is why people kill themselves, is because it hurts. The psychic pain of a depression will always make you not feel pleasure, because your brain is busy with a very uncomfortable sensation. I've never been depressed, except, having a bad day. It's not depression. But judging by the hundreds of people that I've seen over my career, if you've been depressed, you know what I'm talking about. It's not having a bad day. It's a pervasive negative state. And one of the things we tried to get an idea about was, since you can't really simulate that kind of mental pain, you can at least have people, you can at least map what grief is like. Bring up, even in healthy people, a personal sad memory. And what we found was that by looking at how different treatments change the brain, we looked to see where the overlap of brain areas that were provoked when we made people sad, and we started to get a pattern. So that treatments across the board will end up impacting this region here. You can see under depression recovery, the subgenual cingulates, Brodmann area 25, and the anatomical tables. It also goes with having low activity in your frontal lobe. So when you correct low frontal activity, you also drive down cingulate activity, and they're yoked. And so when we did experiments on provoking even just losing a loved one, a pet, taking care of someone sick, something that you can personally activate as making you sad, we saw the exact opposite. Activate area 25, turn off the frontal cortex. So we started to take these big number of regions that went with our treatments to actually isolate in on the relationship between the cingulate and the frontal cortex. And just because of the dominance of the cingulate activity, we decided that that was a targetable location. We knew that that region needed to downregulate its activity, or you didn't get well with treatment. And that was really the rationale. As you can see, I showed you the size of that wire. It's like angel hair pasta. It's not a nano fiber, as I'm sure someone in the audience has probably built already. But you've got this a centimeter long active area on this lead. You've got contacts that are 1.5 millimeters cubed, so the length separated by 1.5 millimeters. And we've got kind of this blob that we can kind of stick a lead in there and have 1 or 2 of the contacts be right in that hot zone, that red area here. And so basically we made an approximation on an MRI scan and figured out where that approximate hot spot was across all the experiments. And we basically put one of the leads in there. We also knew back at that time that what turned off activity in movement disorder and Parkinson's was that high frequency would sort of jam the circuit. And we very naively said, well, high frequency gives you depolarization block. Well, that's sort of like wanting to turn down metabolism, not. But that was our logic. I said, we'll turn on high frequency stimulation in the area that we'd like to down-regulate, and we'll see what happened. And that's what we did. We put it in, turned it on, and I'll tell you a bit about kind of what happened, but acutely, not on every contact and not at every current, but there was a threshold of current that when you turned it on, the negativity just kind of went away. And if you turned it off, it didn't come back immediately, and then the patients were sort of confused if it was there or not, and we sort of ignored it. Nothing bad seemed to be happening. There was nothing we could do to make it worse. So we left it and picked a current that kind of went with what the Parkinson's disease people had been doing for, at that point, for over 10 years, and looked to see what happened. And here's what happened in the first 6 people. This here on the y-axis is a Hamilton Depression Rating Scale score. It's basically a severity rating, self-report. It's been standardized. It's used in all the clinical studies. I want you to file that because it's supposed to be some kind of, ground truth. Again, not, but the best we've got. And if you just look at what happened in the hospital and we didn't know what we were doing, we kind of gave a little stim every day. We were going to do a scan at the end of the week. And actually, you can see that that score dropped The dotted line is a 50% drop in a person's score. That's considered a win. 50% response in any clinical trial is considered the response threshold. And as you can see that everybody, there were only 6 of them, but 4 of them that eventually got better and the 2 that didn't, all kind of showed this effect acutely. Within the end of the week, we implanted the battery pack and gave them a week rest and actually saw that they sort of regressed a little bit as a group, but you know, we just sort of, we'd expected it from Parkinson's disease. You turn it off, it goes away. In Parkinson's, you turn down the frequency from 130 hertz. If you turn down the current, if you turn it off, you've got about 20, 30 seconds before a tremor will come back. And you turn it on, it stops immediately. This was more subtle. Wasn't really quite clear, you know, rapid acting antidepressants was not something that was known. And so you can see the course over the next 6 months of coming in, making adjustments, that after about 2 months, you got this separation of 4 people got substantially better and 2 people did not. And we were pleased, nothing bad happened. These were patients, just to share, it's not like a first episode. These people were people who had recurrent depression. They'd all actually had now in this episode had failed electroconvulsive shock therapy. They had on average had failed over 20 medications. The number of medications these people came in on was nuts. I mean, you know, who comes in on, you know, 10 medicines? You know, you kind of keep looking for a Hail Mary pass of doing something. These are profoundly ill people. So if you know people who are depressed, these are not common. Okay, so to be an ECT failure, I just want you to appreciate who we would think to put electrodes into. People with basically had exhausted options. And it took us a year to have anybody refer us a case. But we persevered. We expanded from 6 to 20. You can look now at the continuous stimulation over a year. This is on average. We had a 60% response rate. Again, not blinded. We had no idea what would happen. You don't want to start blinding before you know what's safe, what happens. You might do good for a while and then it goes away. Maybe you get side effects. Maybe you crash. I mean, you know, it's totally unknown. So that was the approach, just open label and see what happens. And when I moved here, we enrolled another cohort of patients. You may know Bob Gross, a neurosurgeon at Emory. He's also in the BME department. He's our surgeon, new set of psychiatrists picking the patients based on their own thoughts on meeting the inclusion criteria. And again, you look at the curve, they look very similar, but now we had our first clue that maybe it wasn't for everybody. We only had 41% respond instead of 60. And again, that's only a few people in a small study. But again, you know, when you start to have variance, you start to be able to figure out actually what you're doing. And over time, I want you to appreciate that in the Toronto group, actually, let me just go to the next, one of the important things to know was, you know, we designed the experiment that, well, we had a logic, but it probably wouldn't work. And we would need to know why, in order to justify why had we implanted people. So we did, you know, what we knew. We did PET scans at the beginning, and then we did PET scans late. And actually what we found was that these people had overactive 25 and low activity in their frontal lobe, like they're stuck sad was sort of the pattern. And we reversed it. So first time out of the box in that small sample, we were able to at least get some supportive data that we might be on the right track. So what happened going forward? Well, in Toronto, they now have patients. First patient was implanted in March of 2003. So it's a long-term experiment because, you know, if you're doing well and you have an implanted device, there's no reason, if there's nothing going wrong, not to keep it going. And so their long-term follow-up at 6 years was around 60%. So if you got better, you stayed better. We now have a 10-year experience, and actually we're doing a little better than they are in Toronto. Of the original group in Toronto, they've explanted, you know, they have 5 years on us, but they had 2 suicides, late, actually in people who have gotten better. So again, it's not as straightforward as you only kill yourself because you feel bad, and that's a whole other discussion. We had patients in Toronto die of cancer, had other problems, died well, but of other things that you get when you're middle-aged or older. And people just kind of float away, lose to follow-up, usually not because they're doing well, because batteries die, you have to replace them. So they have half the number still enrolled. We did 34. Actually, this group, this slide is of 28. We explanted 3, only 1 for non-response. Patient after 5 years decided he didn't like having a machine in him, take his chances. Another patient actually didn't like being well. Go figure. That's for the analysts, not for neurologists. But what I want you to see is that if you got better, you stayed better. And we started to explore things like, well, does your brain heal? After 6 months, what happens if you do a blinded discontinuation? Well, over a couple of weeks, it's not like movement disorder where you start shaking immediately. It's a slow drift. Takes several weeks for the score to go back up, kind of creeps up on patients. It's not a slam, I feel bad. You turn it back on, you recover it. And actually what we've seen over the course of 10 years is as batteries die, when patients are home, that they come in because they start to have symptoms, and you can start to model what is the time course and can you recapture? And this is actually the most meaningful. When you tell someone, well, sometime over the next 2 weeks, I'm going to turn it off, people start to get nervous. What you really want is just the thing stops working. In dystonia, a movement disorder that takes slow to recover, a movement disorder where people are twisted and have fixed postures, that takes a while to go away. And there was experience that batteries would die and patients would do fine. Not everyone, but that you don't necessarily have that jamming signal like you have in Parkinson's, where it's like noise canceling headphones. You interrupt an oscillation, and when you turn it off, it comes right back because you didn't fix anything. Question is maybe there's some plasticity, maybe you don't go back to where you were. And well, it looks as though that you can recapture after you reimplant the battery, but we're not fixing people in some kind of plastic way. It's not like you have a broken bone and have a cast for a while and the cast can come off and just rehab. So other people have taken this logic, different kinds of logics. People have looked in the reward system directly. I take the attitude of, to implant someone, profound. Depression can be modeled as everyone has anhedonia, low response to pleasure, low motivation. Not everybody has mental pain. And so you can model or think about pushing positive, pushing motivation as your primary driver. To me, I kind of go like, just turn negative off. And it's pretty clear from talking to the patients we operate on that we don't give them anything. They make it very clear. You took something away and man, the rest is up to me. And that is fundamentally an important thing to think about in terms we have to model this. People have tried looking in the habenula, part of the negative prediction error pathway. People have looked directly in the medial forebrain bundle to really push motivation. These things work. It's a little harder to maintain the state, which is an interesting fundamental question. What's happened is that as this has rushed, I would say, by industry to do clinical trials because these open label studies were so, it's not my word, I never thought it was miraculous, but when people this ill get better and you have enough of them and they stay well, everyone says, how can we get this to market? Do not do that before it's time, because there's nothing more agonizing to see a 90-person trial fail. Not because it doesn't work, but because your endpoint was wrong, you didn't consider variance, and so St. Jude actually did a pivotal trial of what I just described. They got to the halfway mark with 90 people, and at their chosen endpoint, active didn't beat sham. But because they're implanted and continue to treat over many people out past 5 years now, they looked at 2 years, 50% response rate. So failed trial, working in people, same kind of problem with the battery dying and needing to replace it. And so we have to kind of think about, everybody gets excited, then your hopes are dashed, then you pick yourself up, and just like all good Zen practitioners know, fall down 4 times, get up 5. And the question is then, what are the ways to get yourself out of a jam? Because if you don't really, just like what's the logic to go in, pick a target. You can have lots of different logic trees, and then you've got to test it. The same way as when it doesn't go the way you think, then the question is partly, what do I do? And the starting place in that is, whose fault is it? And I say that as a joke, but that actually is fundamentally the point. How do I figure out what went wrong? By figuring out whose behavior can I change? What variable can I change? And the choices are, blame it on the psychiatrist. Everybody blames them because they've got witchcraft for how they choose subjects. And they can know how to take care of patients really well, but they don't have biomarkers of who they're picking and why. You can blame the surgeon, miss the target, bad surgeon. That's actually a good one to blame, not because you want to annoy a surgeon. Never annoy a surgeon. They are the most critical piece of this besides who the patients are, but that their behavior can be modified much easier with data. And then, you can blame industry, they jump the gun, don't go there, you're not changing them. And you have to always consider that maybe you got lucky, you had some really spurious finding, and people get magically well if you stick stuff in their brain. I mean, you better get well, it's expensive, it's surgery. Okay, I can accept that, or logic was just wrong. Or it's all placebo. I think the discontinuation means it's probably not placebo. So we went with, because we're imagers, I'm an imager primarily, is go to the where. What is different? Maybe let's start with the simple-minded notion of the surgeon was not as precise as we thought they were, because how would we know? Well, we can look in standard space at where it's implanted. In Toronto, actually, when people saw this data that responders and non-responders had a wide area being stimulated, it says, well, it's definitely not a surgical problem. It's kind of a big sweet spot. You can kind of take the average of that and aim at that. Very bad. Bob, fantastic surgeon, puts it in exactly the same place every time and does no better at explaining responders and non-responders. But we had a clue back from the PET scanning in those first 6. Here was the change pattern. We said, in responders and non-responders, we get decrease, blue is decrease in activity. We don't miss the primary target. But if you look at, follow the yellow circles just for handicapping, but look at the pattern of where there are other areas of change. Red is increase, blue is decrease. There's this missing stuff in the non-responders. It's not getting out into the periphery. It's not getting into the network. And we had an idea of what the network was. We had maps of white matter. We picked it to be hitting 25, but to be hitting connections of 25 to all the areas that we'd seen with other treatments. And at that time, we didn't have tractography. And now we have white matter, we have methods with diffusion imaging that we can map the connectome with imaging. And so we went to look at, can we model backwards what's good and what's bad based on that? And with Cameron McIntyre, biomedical engineer, and Ki-Sung Choi got his BME degree here, we look to see what are we hitting. And the logic for the neuroscientist, psychologist is, look, as I've kind of made a joke, people can be non-responders for many reasons. But if this has something to do with us getting better, then they ought to share something. So let's not compare responders and non-responders in small samples. Let's look with the imaging, what do we hit in everyone? And every voxel has to be shared by every responder at 6 months. And what we got was this map, and we modeled it with tissue models that Cameron McIntyre writes about. And what we found is there was an identifiable map shared by everyone on their tracks based on where they were being stimulated. If you started to look at, well, what was the same or different between non-responders? Well, we got most of it in non-responders, but obviously not enough. And we put in one on each side, and we found that we were missing one or the other of the subcortical connections to the basal ganglion thalamus, and more importantly, the forceps minor getting to the frontal cortex. And we could prove it by the fact that we had people that, by trial and error with a psychiatrist, changing which contact they were stimulating over time, that we had converters, that between 6 months and 2 years, people who had changed. And the team said, no, it's about me. I changed their meds by 5 milligrams, or I added some treatment. No, you can't control that. You can control, did you change the location? If you only looked at where we were stimulating in people that converted from non-responders to responders, that over time, we recaptured the missing regions on the track maps. So I said, okay, we've got a revision of how we might want to do our procedure. It's not a spot, eyeball it X percentage from the anterior commissure to the front of the corpus callosum, and we'd sit there, 2 surgeons and me, we'd look at coronal images in the OR and say, oh, I think I see just enough of the basal ganglia, go there. I mean, this is how we did it. I mean, it's total subjective witchcraft, like making spaghetti sauce, by group. This is now our new template. It's 4 bundles. We're at the intersection of 4 white matter pathways. And we can drive around on a single deterministic tractography map on a laptop and drive around with a little cursor modeled about the size of the volume of the tissue activated at the current that we use, and we can find the place that gets our template. We basically did that in the OR, that Ki-Sung wrote a program for us to do that. We would sit and eyeball and transfer where we were to Bob, the surgeon. We'd all agree that we were in the same spot, and then over the course of 6 months, we left it there and never changed it. And what we got is this curve. We had 8 out of 11, 73% better at 6 months compared to the 41 we had with trial and error by the psychiatrist. So, and we had one patient that we went back and looked at the track map and said, oh, there's another contact that might be equally good, changed it, and that person converted. So this is now our routine. And so what's the next thing we want to do? We've now eliminated a huge part of the variance without asking anybody else to change any of their behavior. And when you run a team and herd cats, as this team is, you have to kind of pick your battles, because people need a justification to change their expert, instincts. And so with this now, this is how we do our surgeries, and now we can concentrate, as I'll show you, on trying to actually standardize other things to understand what we're doing. So let's talk a little bit about the what. I mean, what changes with chronic stim? And I told you in those first 6 people, we said, well, this is going to take a while. We write our ethics permission. Let's look, partway. 3 months sounds like a good number. We'll wait to see. It's going to take a while to figure out what we're doing, and then 6 months. And you can see that whatever the switch was of going from sick to well, we missed it. We ended up doing 2 PET scans pretty much in the same state. And the 3 months change and the 6 months change were the same. So the question is why was that such a bad idea, and what might we do different? So I think that it kind of goes back to, what did we think we knew at the time? This is the logic in the field, that you're sick, you got some number, time passes, you pass some 50% threshold, and then you're well. It's kind of this linear process. That's why you wait a period of time. And let's look at the data. So we've now got 3 cohorts. I've got in Atlanta. We've got the original group that we just did the anatomical targeting, and new team figuring it out. We had a blinded first month. And you can see that red line, it kind of goes down kind of slowly, is a little more linear. The green line is that second cohort where we knew exactly where to put it. We turned it on a little bit in the operating room, again, a month off. But look where they're starting after a month of nothing, having gotten exposed to good stim in the operating room. It kind of goes down, and then you have a couple weeks on and you start to see this decrement again. It's not linear. And this third cohort is our latest cohort, where actually we do repeated stimulation in the good spot in the operating room, because we wanted to record. So we're trying to do it many times. They come out of that operating room and they don't regress. And then you turn it on again, it's like they've been primed. They're getting better much faster. So we have something that the data is telling us that we've got to think about it a lot differently. And so now we have to actually think about what are models of what we're actually doing. That are we doing something that's totally plastic, or do we actually have some sort of a local minimum that these people are stuck, and with the right location and the right threshold of stimulation, we pop them out. And maybe you don't pop them all the way out of that hole, they fall back in. But maybe you can pop them out and hold them there for a while, and then as you do more stim, there's a different time activity curve. So this is one model to think about. The other that Vineet has been trying to think about is, and that, looking things up, it's more of a homeostatic plasticity model, is, you start here, you turn it on in the right place, it goes in one direction, and you turn it on and it bounces around until it kind of gets trained in the right space. And, with Rob Butera, Chris Rosell, you can model these in different ways. But the idea is the data is telling us that just linear is not good. And what other evidence do we have? Well, we did PET scans here as well in that first cohort. And we looked at our responder, non-responder, and made the following observation. I went back to this data that had been sitting there for 5 years that I couldn't really understand before, but with this new idea in mind. So if you look at regions that are directly connected along the white matter bundle, you actually see this pattern. Responders are equal to non-responders. At the target, remote from the target. These are scans done before surgery, a month after surgery where it's been off for a month, and then at 1 month and 6 months of active stim in that same location, same setting. It's done already in the OR, in those regions. You reset it. And then there are regions that are second order connections, not directly in our blueprint, like the prefrontal cortex, premotor cortex. They're in lateral cortices, that they don't change from exposure to stim in the OR, but you turn it on, you start to see that it goes up. And here's just an example of both groups look good at a month of stim, maintained in the responders and lost in the non-responders. So again, something to model. Where should the signal be detected? We've got ways to do that now, but this is setting the stage for how could I follow that? And the way to follow that now is what we've been doing in our third cohort of patients, where how can we look at where before we could only look in the OR, wire them, make measurements, try to capture local field potentials or EEG or ECOG. Now actually the device company has split the standard pulse generator into two parts. Half of it has got the conventional clinical deliver the stimulation. The other half actually has got a recorder. And it can record local field potentials, not great, not for long, but chronically. You can collect 15 minutes of LFP off the electrode while it's stimulating. So you can divide up 15 minutes, you can take little epics over the week, you can bring patients in every week, and you can follow along at what's happening at area 25. So if the story can be modeled at the target, we can do it. And as backup, well, we know that remote changes is actually where a lot of the action is. that maybe the network will come back and there'll be a biomarker off that lead. That would be great because it's implanted, it's easy. You could model the information there because the network changes, it's going to impact 25. We'll have to look, but we're going to hedge our bet. We're going to look at high-density EEG. Brian Howell in the lab is doing very elaborate biophysical models of what we're actually stimulating so that we can know, is the template really what we think. We're starting to think about how can we monitor patients in ways beyond asking them how they're doing. And we've started and have been for a while looking, particularly in the operating room, at things like skin conduction responses and heart rate to really get a readout of the autonomic system because that's right in our network. And then something I want to show you is actually we can see that these people are different. You don't have to talk to them. You just read it on their face. And the question is, okay, then let their face tell us what's happening. So we started by saying, let's get an idea in the OR to kind of type what's the behavior of things people say. So, people have read about this. It's very dramatic. This depression switch got written about, which always kind of annoyed me at the beginning, but it is. And it comes in kind of two parts. There's kind of a change in the state of the body where people feel lighter, they can breathe, they say all kinds of like really interesting things. But if you line them all up, we call that an interoceptive awareness change. And that happens actually when you're in a contact that hits the cingulate. That's what's in common, right or left. And that it's seen in, it's not a specific signal, so it's a partial effect. When you get this and then you get this second behavior, this is the good behavior, this is the dramatic one. People feel connected, they feel like doing stuff, they say all kinds of funny things. Like one guy says, oh, the tension is gone, I could walk my dog. One guy wanted to clean out his garage. I mean, it's just, they're great if you're writing your memoirs to describe these funny things that people say. But what they're saying is, there's stuff I want to do, the brake is on, I can't do it. Oh, the brake is off, okay, go. It's not happy, it's not like I feel like going to Disneyland. It's not a hedonic seeking thing. It's I'm kind of like locked in and now I'm not. And so what they're thinking about, it really is a willed action. There's things I've talked to Lena about, that really this is this intersection between the motor and the emotion that's part of movement disorder and is part of depression. And that's when you get the cingulate but uniquely get into forceps minor, into the bilateral frontal lobes. So we've got actually a readout of when you're in the right. It only happens on the left. So even the good one on the right doesn't produce this phenomena. The good one also gives this big jump in heart rate, well, big jump, 4 beats, but a demonstrable, type 2 effect versus type 1 effect. So we're starting to get even an autonomic readout of this self-report, so that's quite interesting. But the most important thing is, can we get a readout that could actually help you to know in the operating room that you're in the right place? And what Otis Smart did, he was a postdoc in Bob Gross's lab, an electrophysiologist, was to actually try to model what is the effect the first time you hit the right spot from the tractography. So we know where the right spot is, it gets them well. We looked at when that happened, when we were stimulating randomly along the 8 contacts. And what he got is, if you're looking at left recording or right recording, the left side in blue gives a big broadband change in the local field potential. The right side doesn't do a lot to the left side, so it's not a lot of crosstalk. If you're doing the right recording, the ipsilateral stim also gives a big effect, but it's much more limited. So we've already got, just like the behavior, just like the autonomic, that the 2 hemispheres are not responding to stim in the same way, even though the tractography is identical. You're hitting the exact same connections on both sides. So you have something biologically different on the 2 sides. And this drop in the alpha on the left actually predicts how fast they get well. So do I think that an alpha decrease is what happens? Long term, no. But this effect in the operating room, when you turn it on and you turn it off, and what happened, what's the net effect, seems to predict something that we want to put as a placeholder. The other thing that's good is if we look at that good spot that we know gets them well versus the adjacent spot that we know doesn't work, again, the main bands that are driving the specificity are theta and alpha. So we've got two things going for us there. And now we can start to look at what do we have in the cortex. And this is postdoc Allison Waters' work, is let's see, again, when we're in the right spot and we go at 2 hertz, can we actually get an idea of what the cortical response of the brain is? And it turns out that there's a 100 millisecond, very reproducible, evoked potential response that starts at the target, moves to the front of the brain, and then sweeps over the back of the brain consistently in a person over months, coming back every month, and across people. And if you want to look as, could you use that to know if you're in the right spot beyond the tractography, verify the tractography? Well, here's being in the right place and the wrong place, adjacent in 2 people. This person, the adjacent, wasn't so bad. But in this person, you can see just by looking at the ERP topogram that you can tell you weren't getting the 40 or the 100 millisecond part of the sweep. So starting to get a tuner from the electrophysiology. We've even started to look to see if we can decide on what dose to use, because we usually use about 4, 4.5. We have to turn it up. We start at 3.5. Well, here it looks like 3.5 is very different from 4.5. Maybe we started too low, so that maybe we can actually pick a first dose or let the brain's response tell us what the right dose is for a person, because different people may be different from each other. And we can then even try to look at maybe when you give the therapeutic stim, not 2 hertz, but 130 hertz, not unilateral, but bilateral, what's the net effect we want? And this is Vineet's work that'll be in his thesis. It's very preliminary. That just in alpha, this is the response if you're in exactly the right place. This is therapeutically what that person's going to get the first time their brain, a month after surgery, gets the therapeutic stim. And this is what it looks like if you're adjacent. Is sort of backwards from what you'd think, that actually at alpha, if a totally noisy signal, the wrong place, it's like being on your radio. I'm looking for the station, I got static until I'm in. And so modeling this is going to be really important to know, not just at alpha, it's just, I'm the worst person to talk about electrophysiology, so it has to be dumbed down for me. But the idea is, this is not just a map of location, it's which band, in what location, in what model, and that's going to take some machine learning prowess that I think there's a lot of expertise here. But what we really want to know is, we've got that thing in their chest, we're measuring all the time. Can we actually get a readout of what's happening at area 25? Is there something that could help us to tune it, maybe even have a closed loop? And Ashan was here from University of Maryland on a Howard Hughes for a couple of years and went back to medical school a couple of months ago. He took the brain radio data and he did a very simple analysis of the 1/f noise slope. He brought them in, they came in every week, we did a recording in the lab, and he modeled what happened in the left side and the right side. So I told you about the 2 sides are not the same in terms of behavior, not the same in terms of their acute response with Otis's data. The left side goes, gets a flatter slope, starts steep, and gets flat over time. And the right side actually seems to get steeper over time in terms of this noise slope. They're doing something almost the opposite of each other. This is quite significant. This was noisier. But then he looked at, let's just see what's happening every week of what your severity score is. Let's just look at the behavior and the slope. And what you get on the left is, you get flatter if you have a partial response or a full response. There's a binary effect. You're sick or well at the level of slope on both sides of the brain. So we're starting to get a readout that we might actually be able to use to tune, but it's not continuous. It didn't really work well until we said sick well. I want to just kind of end with the idea that this concept of the reset is really important. We're seeing that there's kind of 2 basic states. Sure, I'm sure there's a middle state, But behaviorally, we know this too. This is data on the self-report symptom. You see it goes down, it looks pretty stable, and then it starts to get unstable after they're actually doing kind of well, after like 2.5 months. Here's one patient, they did really great, and then they lost it here, and then they settled back down. Here's a person who did great for 5 months and then lost it. Is there a way to kind of have a clinical readout of that? Because the clinicians get to where they think they know what they're doing again. They listen to what they say. They listen to context. They go, oh, I think you're having some life stressors. What I want to know, what the machine wants to know is, when do I turn it up? Maybe you've settled. Maybe it's hysteresis. Maybe you didn't start on the right place. Maybe you're losing the effect. So how might we look at that? Well, the face is really interesting in depression. And she's an amazing cartoonist. And she apparently had depression. And she described that part of what was really bad about depression is that she knew she looked off, so people could tell, but she reached a point where she wasn't sure if what she was feeling and how she looked was the same. And that's this almost emotional apraxia, that your face doesn't reflect where you are. That's a clue. Everybody, you can tell when someone's having a bad day. You go, you okay? And depressed people get to where their faces are not right. They kind of grimace when they're smiling. It's odd. And there's a biology of emotional facial expression, and it's right in our network. In neurology, you learn about facial expression of a spontaneous smile where it's your lateral motor codices. But there's an emotional mimetic system of the face. And it's actually right in the cingulate where we have a dominant abnormality and is part of our network. So we got Shamim Namadi and importantly his graduate student Sahar Haradi, and our psychiatrist, who's the one that says, well, I can tell a rough patch from needing an adjustment, or at least I'm thinking about it. And they went and we started filming every weekly session when the psychiatrist would talk to them. And the first, thing is, how'd the week go? And they have some conversation for a while. And we've got it videoed. And Sahar basically stripped out the audio, took the visual, and did stuff to it, basically looking at the whole face, and then actually applied 3 different machine learning algorithms to those videos. And the first question is, Andrea gave her sick, rough, the transition period, and well. And what it turned out was the most important thing is everyone thought there was this third category. No, there's 2 categories. There's sick and well. And for the ones that Andrea said were transition, that's in yellow, sometimes they looked like the well, and sometimes they looked like the sick. And in fact, by looking at this is now moving to the next stage, we took and reduced this large set of features to 42 features that best characterized the states. And then she set up a training and testing set and said, okay, what do I know to be true? Early sick and late well, I believe. Let's model the system on that. And this is just not real data, but the simulation of the results. What we want to know is, when you're into that 8 to 10 weeks, and there's a question of if you're sick or well, what does your face say you are based on the model of sick and well? And of 62 videos that are in that situation behaviorally, 33 of them, more than half, you're well. Face says you're well. And only, a third of them is turn it up, you're actually sick. So we're looking at this now to actually use as the readout rather than talking to patients to try to make inferences about their behavior. So I just want to end with the idea that, the last thing is, can we actually figure out who to pick? And again, I trust the scans, because we have scans, or at least it's something we can model, and we've already learned from actually studies of drug and therapy is that with PET scans, we've got biomarkers that if your brain is in the upstate, you do great on drug and therapy will not touch you. And if you're in the downstate, you do great on therapy and drug won't touch you. And we can make predictions. So can we do that by thinking about treatment resistance? We've had this clue that treatment resistance is something to do with this area 25. So we started to look at the fMRI. How are regions connected to that different in different kinds of resistant patients? And it turns out that the connections to our friend the frontal lobe doesn't help us to know who the DBS patients are. But 25's connection to that mid-cingulate, that area that we had the hypothesis about the face, that's only in DBS patients. So there's something about that last connection in our circuit that seems really important to this kind of patient that might do well with this. And I put this in for Constantine. You didn't think I was going to do this. I did it. The idea is now that we know that the imaging can help us, we can start to look, as he did with his graduate student, as new methods to model the network. This was done with a group of regions before we even knew about our template. And as he's done this really interesting new approach to modeling, is here's 25 kind of at a nexus between different groups, and we can start to subject our data to these kinds of analyses as well. So I'm just going to end, and I realize I use the time, but we can talk after. What you realize that this is a real collaboration between people taking care of very sick patients. Because when we're wrong, we still have people we have to take care of. We have to do our best. We have to improvise. These people have got devices in their brain. We have to help them to make educated decisions. We have to keep them well. If you listen to what they say, you actually realize they told us all along that, you know, this was not an easy thing for me. And the longer they get out, the more they're sure that we didn't actually properly consent them, that we hadn't told them how much work they would have to do. They didn't have agency to be able to deal with the idea when they were in the pit where they were going. But, you know, we're not happiness devices. This does not change people fundamentally. This allows people to be whoever they would be if they weren't constantly sick. And I found this, as I was going through my computer, I pulled this obviously many years ago. Recognize that curve? If you can everybody read it? This is the funniest thing because I think I need to take this one out. This was usually my workhorse about what we do or don't do. You know, because people want to be somebody else. No, you know, sorry. It's kind of a buzzkill, but we return you to who you were with kind of a long delay. I mean, life is hard, but it's better if you're not depressed. But getting through this notion that you're out of the pit, but that really, you know, you just sort of want to be even keel, and life has ups and downs, but most of the time it's just kind of not tripping. And I'll end there. I'm sorry I used up the time. I know everyone has to go to class, but...
Yeah, maybe does anyone have one brief question before we kind of wrap up and take the comments offline?
I have a question. You talked about using some of your biomarkers to figure out what your voltage could be, but you also talked about patients who, if you stimulated more in the OR, had this sort of amazing recovery. Mm-hmm. Do you think you could stimulate in the OR until you reach some of those biomarkers?
Oh, I think you've nailed it. So one of the things that we want to do in our new grant is actually do the ERP in the OR, so that actually we could see if you need high density to see the signal. So right now we know where the source is. We know what sensors give us the major effect, and the OR, you can't put 256 channels on the head. I mean, if it was epilepsy patients, you'd have stereo grids, but this is where would you put it on the surface? Conveniently, because we need that frontal pole and something at the vertex, we can work around Bob's surgical space. So the plan will be to do that exactly as we did in the lab, and then can first see if we can get the signal, and then we can start to see if we can make a guesstimate on the dose. So the thing we'd really like to do is it may be individualized. I didn't have it in the slide, but some patients you see a step function at 4 volts, not 3.5 volts. So it really may be that you can set it based on the dose response curve Or it may be that because those initial things were done later, it's already settled. And there's a reason that we go, a month and then have to turn it up. So did we undershoot at the beginning, or is no matter where you start, it's going to settle from a homeostatic plasticity point of view, and you're going to have to push it up. So I think, that could be a marker for tracking along the device. So, in a perfect world, we'd work harder on the signal on the device, because then we could actually model it in real time without having to put another lead in someone's brain. And you could always do that. And people do that, but less hardware would be better, less stress, less things to break. So if you're a nihilist like I am, it's like less things to break as opposed to more data. But no, perfect question.